Of Miss Pinky, 29 years old female. She presented to us in the OPD with a lesion in her scalp, on her scalp in the vertex area. She explained that the lesion was she noticed it since 3 to 4 months, and it was growing fast in size. There was no history of trauma, no history of discharge, no history of pain in that area. Last year she has underwent a surgery for lipoma in the area which is nearer to the present lesion, and the scar she feels is separate from the lesion which is currently present. She was also complaining of another bump-like feeling near to the primary lesion which she is complaining of right now.
Anything else, Ojas? You can keep on talking while you're looking here.
So on examination, it is a swelling of size 2 into 2 centimeter over the vertex of the scalp. It is firm in consistency, non-fluctuant, non-compressible.
This is a case of, this was the previous scar that Agni was referring to. Scar. And these are the two lesions for us, although this is the one that she's come with. It's only after shaving that you'll be able to appreciate the actual size. And by the look of it and the fact that it is growing rapidly, rapid growth, and initially we thought a recurrence because this was operated earlier, although we know the scar is different, and that came out to be lipoma. So this is basically a case of dermatofibrosarcoma protuberance, known as one of the very slow growing soft tissue sarcoma involving the skin and the appendages. Scalp is also a site, and face is, head and neck is quite a common site. Now you can see the bulge over a bulge, there is a part which is extra, there is one here, and there's a layery growth, right? More like the tuber family, potato kind of thing. It's known to recur very frequently. The local recurrence is a problem. The other thing you would have described in all head and neck cases, the rest of the scalp, lymph nodes, because it's not common to have lymph nodes involvement. And where would this area drain? This is occipital area, no? So it will drain into occipital lymph nodes or posterior triangle examination, and they're all negative. And we are planning a wide local excision, which should be at least 1.5 to 2 centimeter of margin, and we'll try to incorporate both of them in one go, and then using a transposition flap. But the only problem with transposition flap would be we need a graft at a donor site, and this resection should go. We have already got the investigations done, including MRI, X-ray skull, CT scan, everything has been done. We know that bone is free. Bone is not involved. And periosteal reaction is there. And we can share that picture also. And this would be down to the bone that we'll resect. And in the center, there's a depression. We may take a few chips of the bone for just a cavity shave. Otherwise, we need to go deep, as we have a barrier, which is a major barrier here, is periosteum. So if you lift it along with the barrier and you leave the bone intact also, it is possible, but we need a flap to cover, not a graft, because patient may turn out to be, if it recurs, may need radiation, and for that you need a flap, not a graft. And the other thing is, graft leaves it's a hairless area then, no? It'll leave a cosmetic deformity, although this all gets covered with hair, but patient should not have any of this. This scar we are not touching because it makes no sense, because it was done long ago. Otherwise there will be completely a battle scarred scalp, which is not a good thing to happen. So the plan is wide local excision, which I've already mentioned. Their depth would be up to the periosteum, right down to the skull bone. And then we can even do a Limburg flap here. We can measure the long axis as we normally do. and this is transverse axis. 50% of this you measure, isn't it?
Yes, sir.
That becomes one limb. A, B, C, and D, and this length you go further up. So the excision, suppose this is your excision margin, then we measure this distance actually, and we go further down with the same distance and
AC is
do a
equals to
parallelogram. This becomes E. So E will come where we have presently BC. Sorry. So E comes to C, and this is how it will eventually heal up. That can be done, but the only problem in scalp is mobility of the flaps. So it is easier to do it in other places than in the scalp. So don't go with that idea. In the neck it becomes very easy. But there are various other methods of doing it. This is one method. You can do Limburg or rhomboid flap as they call it, or simple transposition. It's a case of sarcoma of the head and neck, and we have a video of face dermatofibrosarcoma which had been excised along with the orbit involved in that case, and we had done a radial artery forearm flap to cover up the whole nose, face. You need to see that picture, and if possible we'll try to share with this video. Any questions regarding this surgery? We'll try to record this surgery also and share. The investigations also you can share and chip in. Any questions?
So regarding the margins, regarding the bone and the depth of the bone, how much margin in the skin and the subcutaneous will go for up to 1.5 to 2 centimeters, but how much area of the bone, how much depth of the bone can we take out safely in this patient?
See, actually, soft tissue sarcomas tend to recur more frequently than any other cancers. Can you tell me why do they recur so frequently?
Satellite lesions which they may
Okay, so they tend to have their these what you're trying to call as satellite nodules are the nests. So it extends beyond the false capsule. So enucleation is contraindicated because you leave behind the cancer. So you go one plane deep, one plane away, and the ideal surgery is you have not seen the tumor at all. But there are places where it is impossible. Say in head and neck, I am doing surgery and carotid is in my 2 centimeter margin. Then I can't take carotid and count 2 centimeter margin. And there comes the concept of major barriers and minor barriers. So the barriers are in terms of facial sheaths, periosteum, peritoneum, pleura. You understand the barrier? So beyond that, there is no tumor. Like in breast, they talk about if there is 1 millimeter margin in DCIS in the deep margin. What is your deep margin? You take in the fascia with you, so there is no breast beyond that. So now you can't take a margin in thin air, right? Or you can't take a deeper tissue just because you are counting 1 centimeter. So it's not arithmetic. Some bit of common sense is also required, right? Which is extremely uncommon, that. So importantly, margin of 1.5 to 2 centimeters all around. And whenever we talk about R0 dissection, Agni, the R0 dissection concept is based on leaving no microscopic disease in 3 dimensions, not in 1 dimension alone. So it becomes relevant to understand that the dimensions are 3, all around you should get a clearance. And naturally we'll use a transposition flap. I'm very familiar with that. It saves any morbidity. The same cut, you can extend it and you can shift it. But the only catch is you need to close it primarily. If I put a graft, unless it's a very tiny piece, then graft the hair. In a male it becomes easier. In a gentleman it's not a problem. You put in a cap on, in a lady it can be a serious morbidity. So there are plenty of flaps available, and there is no shame in taking the help of people who do that job very frequently. So one thing is never ever be rigid with I alone will do it. Get the patient the best person to do that job and get the result which is the best for the patient. So the most important person is patient. What are the indications of radiation in dermatofibrosarcoma protuberance? Recurrent dermatofibrosarcoma. And do you know what? I teach students in soft tissue sarcomas a mnemonic, which is R. What does R stand for?
Recurrence, radiation, and
So the answer is recurrence. And it is not radiation that is going to cover up for that. You must get a clear margin. It is known to recur. So when the patient is asking, "Dobara to nahi hoga," don't ever promise. Under promise, over deliver.
Correct.
Don't show them moon. It is not possible. Just tell them it is possible. Soft tissue sarcomas tend to recur.
Recur.
But the good thing that happens with clearance, this clipping is fine. We don't need razor there. This clipping is very nicely done. We need, how would I start thinking? My longitudinal approach would help me take the flap also. So they get resected and I just have to shift longitudinally. If it is circular, I'll have to create a circle. Understand, as soon as you're resecting, your mind should start working like a tailor thing, So if I resected in this axis,
Vertically.
both come in my book, but in any case, I need a flap which is longer. So I get a longitudinal cut on the other side. I just extend this cut here, lift it up. I leave the periosteum there because I don't need periosteum for the, I need to leave it at the donor side. Suppose I need to put a flap or graft. Suppose I need to. So this will come and cover up this part. So that part, it may not be possible to fill. Even if there's a small bit, which will be better than the scar that she has, so we can manage it that way. So that's the planning for this case. It's a young girl who's an engineer waiting to crack her civil services exam. So